So Ankur, you are ready?
Yes, sir. Yes, sir.
Okay, please start.
Okay, sir. Good morning, sir. Sir, my patient is 78-year female patient. She is housewife from Ajmer, Rajasthan, and she has come with chief complaints of decrease in appetite, weight loss, and weakness for 4 months, and pain right lower abdomen since 20 days. History of presenting illness. Patient was apparently asymptomatic for 4 months. The patient has noticed decrease in her appetite in last 4 months, and previously she used to eat around 4 to 5 chapatis, and now she is able to eat only half to 1 chapati. And it is associated with weight loss from 58 to 45 kilogram in 4 months. And patient also feels progressive weakness with easy fatigue in last 4 months. Previously, she used to do household routine works, but now she prefers to lie down on the bed.
Ankur, you can put your camera on so that all of us can see you.
Okay.
Yes.
So I'm visible, sir?
Yes, please carry on.
Okay, sir. Now in last 20 days, patient has developed 4 episodes of pain abdomen, which was sudden in onset, severe and colic in nature, started in right lower abdomen, and it was involving occasionally whole abdomen also. There was no any aggravating factors or postural variation, and the pain episodes were associated with nausea and mild abdomen fullness without any vomiting, and for which these pain she had to go nearest local hospital. And this pain got relieved after passage of flatus and stool and after IV injection without need of Riles tube insertion or prolonged hospitalization, and she was investigated there and advised for surgical intervention. And in between these pain episodes, she did not feel pain. However, she felt that the pain was increased after taking meal, so she decreased her appetite more, and now she is on liquid diet since a few days. No history of bleeding per rectum or black tarry stool. No history of any altered bowel habits. No history of blood transfusion. No history of fever or evening rise of temperature. No history of decreased urine output or hematuria. No history of leg swelling. No history of jaundice, cough, dyspnea, and headache. Past history. She was hypertensive for 1 year and on oral medications, and no diabetes mellitus, no tuberculosis or asthma, no surgical history in the past. Personal history, she is a vegetarian, and bowel movement once a day, it was yellow colored she told. And bladder and sleep habits were normal, and family history, there was no history of malignancy or tuberculosis in family. Menstrual history, she attained menarche for 50 years, she told. Summary: 78-year-old female patient came with complaints of pain right iliac fossa and subacute intestinal obstruction associated with recent onset anorexia, weight loss, weakness without altered bowel bladder functions.
Okay, maybe you can go back to your first slide and start telling us the significance of whatever you have mentioned.
Sir, she started with first noticing her decrease in appetite. Previously, she told she used to eat more food. Like
don't repeat what you have already said. Just give us the importance. So before that, sir, would you like to comment on her age? 78-year-old lady.
Yes, sir. She is old age.
Yeah. So whenever you are dealing with an elderly patient, if you have any symptoms, in most symptoms, at the back of your mind, there will be either a strong or low suspicion of malignancy, isn't it? If the same symptoms were there, say in a 20-year-old female, your interpretation would have been different.
Yes, sir. Yes, sir.
So it is not that malignancy is not seen at young age, but when you have a middle-aged or elderly patient,
yes,
then you keep malignancy in mind, or at least you would like to rule it out.
Yes, sir.
So start from the age. Okay,
Yes,
next.
She is elderly aged female, and she has recent onset this anorexia, weight loss, and progressive weakness, which signifies means which there maybe in advanced malignancy it can happen, and she is having this weakness along with easy fatigability also, which signifies she may have anemia also.
Yeah, so good. So elderly patient who has recent onset anorexia and weight loss, again, strongly makes you suspicious of malignancy, whichever system is involved. At the moment, once the patient says, I have anorexia and weight loss, we don't know which system is involved, but we would definitely like to keep malignancy in mind. And yes, you are very right. Weakness with easy fatigability indicates anemia. And the commonest cause of anemia in a post-menopausal female patient would be occult blood loss if she has no obvious blood loss. And the commonest site of occult blood loss is the GI tract.
Yes, sir.
Lower GI tract. Lower GI bleed, occult is the most likely cause of anemia. Yes.
Yes. And sir, and she had this pain episodes, which is also recent onset within 20 days 4 times, and started in right lower quadrant. So probably she has problem related to ileus, means right colon or cecum side, and she has she had associated nausea also, and abdominal fullness also. So maybe probably proximal, it means growth is means proximal bowel obstruction can be there.
Go to the next slide. Yeah. So again, as you rightly described in your summary, her symptoms are quite suggestive of subacute intestinal obstruction.
Yes, sir.
Which is a classical history that patient develops colicky pain, which is associated with abdominal distension. It may be associated with inability to pass flatus and feces during the episode of pain, and it may be associated with vomiting or nausea or not feeling like eating. And these are episodes which settle on their own, as she did, that she reduced her oral intake to liquids. Some patients may even fast for some time, and then the attack resolves, but to come back again after an interval of time. So this is the classical history of what is known as subacute intestinal obstruction, which is incomplete obstruction, transient obstruction, which gets relieved either on its own or with conservative treatment over 24, 48, 72 hours, as opposed to complete acute intestinal obstruction, which would not resolve with conservative management. And this history is highly suggestive of
subacute.
Subacute obstruction is classically seen in which condition?
Sir,
it is a characteristic. Yeah, please carry on.
Sir, Cox abdomen.
Yes, so typically it is seen in tubercular
yes,
abdomen, and rather than saying tubercular abdomen, you should say it is seen in intestinal tuberculosis.
Yes.
As we will discuss later, tubercular abdomen includes involvement of the GI tract, involvement of the lymph nodes, involvement of the peritoneum, involvement of the solid organs like liver, spleen, and pancreas. But this history is classical of intestinal tuberculosis. Okay.
Singer, just a small point, nothing in your history, but that, the spelling of that is a very common mistake. You have written 4 months, then, so then the spelling should be THEN, not THAN.
Okay, sorry.
Just, this happens commonly, so you just know.
Yes. Okay, next. Yeah, so on one hand, you say no aggravating factors, but on the other hand, you said that she felt that pain was increased after taking meal. These are contradictory statements. Isn't it?
Yes,
so make
sir,
sure that you don't contradict yourself when presenting something.
Okay.
And you mentioned no postural variation. Why did you specifically ask about postural variation?
Sir, general, sir, means any
No.
real.
Yeah, I get that. So if an MBBS student does that, it is all right. Because we teach the MBBS student that you should ask all these points in the history. But at your level, most examiners, including myself, expect you to give a targeted history.
Okay.
So if it is an epigastric pain, agreed postural variation is important because you are thinking of pancreas as the organ of origin. But
Okay.
when you are talking of lower abdominal pain and you have a classical history of subacute intestinal obstruction, there is no relationship to posture.
Yes.
Isn't it? So
Yes.
I think it would be better that at your level, at MCH level, you mention a targeted history. So same way, if it is a lower abdominal lump, it's not, it is actually absurd to say that it doesn't move with respiration because you don't expect it to move with respiration. So if an MBBS student says that, I will excuse, but not at your level. So your history presentation should be a very targeted presentation. Okay.
Okay, sir.
Next. You said no history of decreased urine output. Why you specifically mentioned that?
Sir, she had, means in my mind, there was suspicious of some malignant pathology in the right iliac fossa, which can involve ureter or kidney. So that's why I asked decreased urine output or hematuria.
Hematuria, fine. What is the most common presentation of an advanced malignancy of the right iliac fossa on the urinary system? What does it cause?
Sir, hydronephrosis or hydroureter.
So what will be the presenting symptom of hydronephrosis?
Sir, right lumbar pain or.
Yeah, so you should have mentioned that rather than, very rarely you will see decreased urine output because of unilateral ureteric involvement in a malignancy. So that is not the commonest presentation. Commonest presentation is hydronephrosis, which is right loin pain.
Yes.
Okay.
Yes.
And then of course patient can have urinary infection.
Yes.
Fine. Next. That's okay. Next. Yeah. So here summary. Summary means you are summarizing. So again, a very kind of nitpicking point, but I would prefer if you say history suggestive of subacute intestinal obstruction.
Okay.
Because that is your interpretation, that is your analysis. Okay.
Okay, sir.
Yeah. So any other faculty members? Subhash, I see you are there. Rajendra, you want to make any comments on the history?
One another thing.
Yes.
Hello.
Yes, please.
You said the menarche 50, na? Is it menarche or menopause?
So sorry.
Yes. Yeah, I also missed that. Good.
Sorry, sir.
Another thing.
Menopause, sir.
Excuse me, can I speak?
Yes,
Yes.
Rajan, please come in.
Yeah. You mentioned there is no presence of black tarry stools.
Yes.
That means there is no melena, which is upper GI tract in origin. Colonic malignancy, ulcerative colitis in the quiescent phase can produce dark colored stools with foul smell, but they are not black and tarry. Acid hematin is black and tarry. So usually duodenal ulcer bleed or portal hypertensive gastropathy or any lesion in the stomach will produce a black tarry stool.
Okay.
With the colonic, right-sided colonic malignancy, usually they do not have any significant overt GI bleed. But you should consider things like angiodysplasia and other problems in the right iliac fossa if there is suggestive of melena.
Okay, sir.
So based on this history, what is your interpretation?
Sir, interpretation is she is elderly female with recent. So she is elderly female with recent onset and this anorexia.
Don't please.
Sir,
Very frequent mistake which students do. If you are asked a question, whatever you have already said, we have heard. So there is no need to repeat that. Now I am asking you, what is your interpretation of this history? You have given history, you have summarized. Now give your interpretation.
Sir, she has malignancy in the ileocecal, probably ileocecal region, which is locally advanced, which has caused these symptoms.
Okay, so you think it is malignant.
Yes, sir.
Why?
Sir, first, she is elderly female,
Mhm.
and she has features suggestive of anemia,
Mhm.
and she has she started pain in the right lower abdomen.
So anemia is a feature of malignancy. Pain is a feature of malignancy.
No, sir.
What is the point in favor of malignancy? What is the
Sir,
strong point?
recent onset anorexia, weight loss.
That is more important.
Yeah,
That is
you
more
have-
important.
You started with that and then you have skipped it when you are answering the
Yeah,
question.
earlier you said that. So
Yeah.
elderly lady, recent onset anorexia and weight
And
loss. These are points strongly in favor of a diagnosis of malignancy.
Yes.
Anemia also, I would agree to some extent, because you should know. And what is the point against malignancy here? Would you like to consider a non-malignant condition also? Not in this patient, but otherwise, what is the differential diagnosis of a right iliac fossa pathology?
Sir, it can be intestinal tuberculosis, ileocecal,
Mhm.
and sir, others can be this amoebic colitis,
Mhm.
and even
Which other organ commonly involved in the right iliac fossa? The commonest disease of right iliac fossa.
sir, this inflammatory bowel disease can be there.
Now I'm asking you a very general question. You should know, when the examiner has changed gears, what is the commonest disease in the right iliac fossa?
As a surgeon,
Sir, right ureteric stone can be there.
Oh no.
You are a general surgeon first, then you became GI.
What about appendix?
appendix?
Sir, appendicular.
Appendicular disease is the commonest disease of the right iliac fossa. Now we are not asking in relation to this patient. So appendicular lump is much more common than amoebic
Yes,
lump these days, at least. Earlier we used to see, but now we don't see an ameboma so frequently. Okay.
yes.
So why is this not tuberculosis?
Sir, in tuberculosis, usually patient is a middle age or young age patient, and she doesn't have any history suggestive of means fever or evening rise of temperature, and usually it is a long history with long duration subacute intestinal obstruction.
So again, age you cannot use to exclude a diagnosis. Age may support a diagnosis. Just as I said earlier, if you have a young patient, that doesn't mean that the patient cannot have malignancy. Similarly, if it is an elderly patient, it doesn't mean that the patient cannot have tuberculosis. It's not that tuberculosis is not seen in the elderly. Other way is right, that when you have an older patient, you think more in terms of malignancy, but it doesn't exclude tuberculosis. Similarly, absence of systemic symptoms of tuberculosis, that is low-grade fever with evening rise, night sweats, malaise, weakness, tiredness. Of course, she has weakness and tiredness, but all these symptoms are not very frequent in abdominal tuberculosis. They are more common in pulmonary tuberculosis. They are more common when tuberculosis involves the membranes like pleura, pericardium, peritoneum, meninges. Even in the abdomen, these symptoms are more common in the more active forms of tuberculosis, which are peritoneal tuberculosis and lymph nodal tuberculosis. Intestinal tuberculosis is usually a less active form. So these patients usually do not have systemic symptoms of tuberculosis. So if they are there, fine. If they are not there, it doesn't mean that it cannot be tuberculosis. Also, as I said earlier, subacute intestinal obstruction is more in favor of tuberculosis than malignancy, because you were saying ileocecal malignancy. See, malignancy is never at the ileocecum. Malignancy is in the cecum. There is a difference. Tuberculosis involves the ileocecal junction. Malignancy involves the cecum, and that is why obstruction is more common in tuberculosis, and bleeding resulting in anemia is more common in malignancy. So anemia is a point in favor of malignancy, but subacute obstruction is a point in favor of tuberculosis. So here it is a mixed picture, but considering the age, I agree that you would like to keep malignancy as the first diagnosis. Because if the malignancy is in the cecum, suppose it is on the medial wall of the cecum, then sooner or later it will involve the ileocecal junction and it will cause obstruction. So it's not that obstruction is not seen in malignancy, but it is more frequently seen in tuberculosis.
Okay.
Any faculty member, any other point, or shall we proceed to examination? Yeah, please carry on.
So general examination. Patient is conscious, cooperative, well oriented to time, place, and person. She is moderately built and moderately nourished. BMI of 20.27 and performance status of peak of 1. She is paler. No cyanosis, jaundice, clubbing, or pedal edema. No significant lymphadenopathy. Pulse is 84 per minute. Blood pressure 126 by 80 millimeter mercury. Temperature 98.6 Fahrenheit. Respiratory rate 16 per minute.
Which lymph nodes did you look for?
Sir, left supraclavicular lymph node mainly.
That's all.
Sir, we can see inguinal also, axillary also.
Why inguinal? Why axillary?
Sir,
so what is your differential diagnosis based on history? It is malignancy and tuberculosis.
Sir, malignancy.
Malignancy, but it could be tuberculosis also, as we discussed.
Yes, sir.
So if you are thinking of tuberculosis, which lymph nodes do you look for?
So it is for cervical group of lymph nodes.
Cervical is not a group. Cervical is a complete region. Which lymph node is characteristically involved in tuberculosis? Cervical includes a large number of groups of lymph nodes. So it is the upper deep cervical, the jugulodigastric group of lymph nodes, which is characteristically involved. So when you are thinking of malignancy, you look for left supraclavicular node. When you are thinking of tuberculosis, you look for upper deep cervical lymph nodes. When you are thinking of lymphoma, you look for any lymph node anywhere in the body, which includes neck, axilla, groin, anywhere. So depending on what you are thinking of as a possible differential diagnosis, you should specifically mention which lymph nodes you were looking for. Okay?
Okay, sir.
Yeah, carry on.
Sir, inspection, abdomen is flat, umbilicus is central and everted, all quadrants moving equally with respiration, and there was no visible lump or peristalsis, dilated vein, scar sinus, hernial orifice were free.
Is there a single hernial orifice?
No, sir.
So then you should say hernial orifices.
Okay.
These are all small points, but we want you to mature into a good teaching consultant. So you have to look after your grammar and spellings also. Hernial orifice means single orifice. Hernial orifices mean multiple orifices. Yes.
So you have written umbilicus everted. That's a normal thing?
No, sir. Usually it is inverted.
Okay.
Sir, palpation, abdomen was not warm, not tender. There was lump palpable in right iliac fossa. It was single, hard, irregular shape, non-tender, having size of 6 into 4 centimeter with restricted mobility and not fixed to overlying skin. And there was no any other lump. There was no organomegaly and no palpable thrill.
What other lump you were looking for?
Sir, if any other means synchronous malignancy or
Good.
is there?
Anything else?
Sir, enlarged lymph node.
Enlarged.
Okay.
Very good. Very good. Yes. And again, go back, please. Rather than saying no or any ergonomegaly, what specific organ enlargement you were looking for?
Sir, hepatomegaly.
So say that there is no hepatomegaly or liver is not. Best is to say liver is not palpable, because hepatomegaly means liver is enlarged.
Yes.
So they are not synonyms. A normal liver can be palpable, and sometimes an enlarged liver may not be palpable. Suppose it is a very obese patient. Even if the liver is enlarged, it will not be palpable.
Okay.
Similarly, if it is an elderly gentleman who has been a heavy smoker, he has chronic obstructive airway disease, emphysema, the diaphragm is pushed down, even a normal liver will be palpable.
Okay.
So they are not synonyms. On clinical examination, we say liver is palpable. And then, as you have mentioned in the next slide, what is the liver span?
Yes.
Yeah.
So liver span was 10 centimeter, tympanic node over abdomen, and it was dull on lump. And on auscultation, there was no normal bowel sounds were heard. And per rectal examination, finger was stained with yellow color stool, no growth or deposits were seen.
So again, it's important that whenever you are describing the examination, you mention specific negative findings which you are looking for specifically. So here, good that you have mentioned normal bowel sound, but say they are not exaggerated. So I know that you are looking for exaggerated bowel sound. Similarly, on stool, you say finger stained with yellow stool, no melena. So emphasize on the point which you are looking for, but it is not there.
Okay.
Ankur, one thing. You did not palpate the right flank?
Yeah.
No. Means, sir, if there was no any lump or fullness was there.
So what Dr. Subhash is trying to emphasize, as
Sir,
we
yes,
discussed
sir.
earlier,
Hydronephrosis,
you
if
have to
there,
look for features of hydronephrosis both in history and on examination, which would be fullness of the renal angle, dullness on percussion, and if any lump is palpable in a thin-built patient, the hydronephrotic kidney may even be palpable. Rare, but it is possible. So you have to specifically mention the examination of the right flank in a patient with right. Similarly, in a patient with sigmoid malignancy, left flank. In a patient with rectal malignancy, both flanks.
okay.
Yeah. So what is your impression now? What is your analysis now?
Sir, mostly, sir, she has carcinoma caecum and very less likely, sir, intestinal tuberculosis.
Yeah, so you should say, see that I think I would like, or you can say I would like to keep a diagnosis of malignancy, carcinoma of the caecum or right colon, but it would be a pleasant surprise if it turns out to be tuberculosis.
Yes.
But your working diagnosis in a 78-year-old lady who has significant anorexia and weight loss and has a hard fixed lump palpable in the right iliac fossa is tuberculosis. So what are the differences in findings on examination between a malignant lump and a tubercular lump?
Sir, malignant lump will be irregular in the shape, ill-defined margins, and with restricted mobility. Ileocecal, there may be some mobility will be there. Ileocecal in tuberculosis. And
yeah, so carry on.
So
So
that lymph node examination.
Yeah, practically speaking, there may be no difference at all. It will be very difficult. But yes, some subtle points you can say that if the lump is hard, if it is fixed, if it is irregular, it is more likely to be malignant. If it is firm, if it is mobile, if it is well defined, it is more likely to be tubercular. But practically speaking, it will be very, very difficult to differentiate between the two. Sometimes even after surgery in the specimen, it is so difficult to differentiate. Same way as we will discuss on endoscopy, on radiology, it is not always possible to distinguish between the two. Okay.
Okay.
Yeah. So anything else at this stage before we move on? Ajay, you want to add anything? Achha. Chalo. Let's carry on. Yeah, Subhash.
The position of the lumps can sometimes be, because in tuberculosis we find the pulled up cecum.
Yeah.
And all. It may be slightly up.
Very, very important point, because as we will discuss in radiology, in ileocecal tuberculosis, usually there is shortening of the ascending colon. So the ileocecal junction is pulled up. So instead of lying in the right iliac fossa, it can lie in the right lumbar region. and rarely even in the right hypochondrium. So if you have history suggestive of subacute obstruction, you can still have a lump much higher than the right iliac fossa. And that is a point more in favor of tuberculosis rather than the malignancy, unless it is a malignancy of the ascending colon or hepatic flexure. Yeah. So she comes to you in the OPD. What will you do?
Sir, first I will tell her about the disease, what she can have, and I will admit her. And I will run 2 sets of investigation. First, I will do blood investigations in form of complete blood count, electrolytes, creatinine, liver function test, and PTA, PTT, INR, and simultaneously chest X-ray.
You said you will admit her. Why she needs admission?
Sir, she has she has anemia and recent malignancy. So we have to she needs curative treatment. For that we have to admit.
Yeah, but at this stage, first you have to investigate her. You have to find out the diagnosis. You have to find out if it is malignancy stage, and then you will decide treatment. This is going to take a couple of days. So admission means that you think that she cannot stay at home.
Sir, she was having anemia, so hemoglobin can be low. So we have to transfuse also, and so
No,
for that we need.
I don't know.
So do you mean to say that all anemic patients you admit in your hospital? Yeah.
See, when you say I will admit the patient, there should be two, or in a case like this, there should be only one reason, that either she is in obstruction or because of anemia, she is in congestive failure. Yes. Otherwise, anemia is not an indication for admission.
Okay.
Isn't it?
All Indian beds with with anemia only.
Okay, so fine. All these, we have the reports of these investigations.
Does this patient have fever?
No, sir.
No.
Evening rise of fever?
No, sir.
Cough?
No, sir.
Productive sputum?
No, sir.
Non-productive cough?
No, sir.
Tuberculosis?
No, sir.
Genital malignancy?
Yes, sir.
No, you are wrong. Now you are wrong, because in GI tuberculosis, none of these features are present. That is how GI tuberculosis is different from a pulmonary tuberculosis.
So again, Dr. Ajay is trying to emphasize the point which we discussed earlier, that absence of systemic symptoms of tuberculosis or absence of symptoms of pulmonary tuberculosis does not mean that it is not abdominal tuberculosis. If they are there, they are supportive.
More so in what Professor Kapoor told, in intestinal tuberculosis. You see, some of the symptoms may be there, systemic symptoms in a case of peritoneal or lymph node malignancy, but if it is intestinal, it's very unlikely.
Yeah.
Yes.
Okay, so let's see these reports, the tests which you wanted.
Sir.
You share करेगा.
Sir, is it visible?
Not yet.
No.
I think is it a separate file?
Yes, sir. Yes, sir. Yes, sir.
So you have to stop sharing,
Okay,
go to your desktop and then share again. Yes.
Okay.
In the meantime, any student wants to ask any questions so far? History and examination? Anybody? Any faculty member wants to make any comment? Yes.
Sir, is it visible now?
Yes, we can see. Please.
Okay, sir. Sir, she means in complete blood count, she has anemia, hemoglobin of 7.9, and other parameters in complete blood count is normal. Creatinine is normal, and she doesn't have sodium electrolytes are also within normal limits. And sir, PTINR is also within normal limit, and albumin is 3.9, which is also normal.
Yeah, good. So again, if you are doing an online presentation or online exam, or if you are showing it in a conference as a oral paper, you don't have to read each and every value. You just analyze, because everybody can read it. Good. Yes. So next, what do you want to do?
So next, sir, to means confirm my diagnosis, sir, first, after means colonoscopy and full length colonoscopy and biopsy, sir, after bowel preparation.
What about ultrasound?
Yes, sir, she had a lump. So first week.
No. You just say question asked.
Would you do an ultrasound first?
Ultrasound.
Because you said colonoscopy, so I am asking a counter question.
Sir, for means confirm my diagnosis, colonoscopy will be preferred. But this ultrasound is simple, means non-invasive test, and she has probably advanced malignancy, so we can find liver space of liver metastasis or ascites in that. So we cannot.
So this is a very catch situation for students, because if you had said ultrasound, I would have countered by saying, what will ultrasound tell you? Why not colonoscopy? So you have to be prepared for such questions. So I think partly your answer is correct. So in general, if you are thinking of a hepatopancreatobiliary disease, ultrasound is invariably the first investigation.
Yes,
if you are thinking of a luminal disease, esophagus, stomach, colorectum, in general, endoscopy is the first investigation. But there is no harm in doing an ultrasound, even in a colorectal or esophagogastric disease, because ultrasound can give you a lot of information, and a good ultrasound will tell you the site of origin of. Here, of course, we have a classical picture of anemia, obstruction, so we know it is a bowel mass. But suppose these symptoms were not there, then it could be a retroperitoneal tumor, it could be a soft tissue tumor. So in that case, the ultrasound is a very good investigation to tell you the organ of origin of the lump. At the same time, it gives you information, as you rightly said, about the spread of the disease, not only to the liver, but to the lymph nodes. It tells you about ascites. It tells you about, as we were discussing, whether there is any hydroureter or hydronephrosis. So ultrasound gives important information, but in a colorectal malignancy, usually ultrasound does not change the plan of management, because presence of even metastasis does not contraindicate resection.
Yes.
So that is how you can answer that question. On the other hand, if you had said ultrasound and I would ask you why not colonoscopy, you could have said that these points you could have mentioned, and you could have said that yes, as a second investigation, I will do a semi-invasive investigation, which is a colonoscopy. So ultrasound is a purely non-invasive, simple investigation. Okay.
Yes.
So let's see.
I think
Ajay wants to say
that rather now the term used for routine ultrasound which has been done is an extended palpation. Most of the things which you feel that you are having a palpatory finding, which when you palpate in something, you said ascites. I would say ascites you can palpate also, or you can clinically examine also. But a mild ascites you may not be able to evaluate on clinical examination. Similarly, liver may not show the metastatic nodules on clinical examination, on palpation. So at that time, just a small ultrasound, that is the bedside ultrasound, can be helpful. So therefore, the term used nowadays is the extended palpation for sonography nowadays. It should be usually available, but with hazards of sonography, it has not been used, but it is extended palpation now.
So that is another point in favor of saying ultrasound as the first investigation. Yeah.
Thirdly, you see, single, when you are presenting in an exam, you are also representing your institution. So what normally happens, what you have seen in 3 years, so you can defend giving that region also. So this investigation, you started with a good answer. You said, so that's the easiest, very easy investigation, non-invasive. So this will give me these additional findings.
Okay. Yes, sir.
So you can add that also.
Most of the times, if you say ultrasound, you should be able to defend yourself.
Yes, simple.
Yes.
Yeah, please.
First or second, you should be able to defend. So this was the practice in our hospital, because easily available investigation. Sometimes you can also say that most of the patients, they come with the ultrasound.
Yes, sir.
So ultrasound,
So-
if you have said ultrasound as a first investigation, you must qualify, and the examiner will definitely ask, as Professor Kapoor has told, if you say colonoscopy, he will say why not ultrasound. If you say it is a non-invasive, it's an invasive investigation, it requires preparation, patient has this thing. If you say ultrasound, then they will say no, it is a thing. So you should be able to defend giving one of the reasons that this was the practice in our centers. And this is the reason we do this.
Another point, although I said that ultrasound usually does not change your plan of management, but there could be exceptions. Suppose it is an elderly, like here, elderly lady or elderly patient with multiple comorbidities, large fixed lump, which you know is locally advanced, and then ultrasound shows multiple bilateral liver metastasis, and the patient is not bleeding, patient is not obstructed, you would not operate upon this patient. Or many groups probably would not operate upon this patient and just give chemotherapy as a palliative treatment. So it may sometimes alter the plan of management also.
Okay.
Can I ask a question, sir?
Yes, Rajesh.
Yes.
Yeah, when would you do a hemoccult test? Would that be indicated in this case, or you want to give it a go?
Sir, when means when? So in this patient, sir, means we are suspecting right-sided colonic malignancy and hemoglobin is also low and feature suggestive of malignancy. So there is no means in this patient there is no need, sir. Hemoccult test.
Is it the lump you are more bothered about, or when would you do hemoccult testing?
Sir, when
What is the role and place? Yeah, what is the role and place?
Sir, when means features suggestive of features are not suggestive of malignancy, and still hemoglobin is low. So, sir, in that case, we can do this.
Yeah, so the
Means
role
there is
and
no
place
growth and only ulcerative lesion is there, and that
no,
time
once you see a lesion, then whether hemoccult test is positive or negative has no meaning. So therefore, its role is only in screening, number one, and number two, when you are investigating a patient with unexplained anemia.
yes.
That is the only situation, because once you have a lump, once you have a lesion, then whether stool is positive or negative is immaterial. Then you have to treat the lesion. So that is only when there is no lesion, when you are investigating unexplained anemia.
Yes.
Carry on. Let's see the colonoscope. Okay, ultrasound done here. Yes.
Sir, chest X-ray normal.
So again, the same point what Dr. Ajay said. Normal chest X-ray does not rule out a diagnosis of abdominal or any other extrapulmonary tuberculosis. But if chest X-ray shows evidence of either active or past tuberculosis, it may be a supportive point in favor of your diagnosis.
But good, you must do the chest
Yes.
X-ray. In a case when you are having a right-sided abdominal right iliac fossa lump, and where still you are debating because 100% diagnosis clinically cannot be, so you must do the X-ray test.
Okay.
Yes. What does the ultrasound show?
Sir, there is means appendix is dilated.
So that's the most important finding.
This cecal mass is there,
So
sir.
why do you mention that as the first point?
Sir, actually, I was reading. I have not seen.
You read in that order.
Take your time, but no examiner would tell you that why are you keeping quiet unless it is a very prolonged silence. So while he is
Sir,
reading it, yeah, okay, carry on.
Sir, means there's a mass in the cecum,
Yes.
largest size 4.8 into 2.03 from the posterior side, and on anterior side also they have mentioned in ultrasound there is hypoechoic lesion. So mostly it is a cecal mass is there, and
No, so are you trying to say that there are two lesions?
no, sir, single. It is single only, but they have mentioned in ultrasound. Mostly,
What else could it be? if they are describing two lesions, what else? One is a larger one.
Sir, lymph node, enlarged lymph node.
It could be a node. One
Yes,
of these
sir.
could be a node.
Node. Yes. And there is
And-
loss.
What else? It is possible that there are two lesions. We know that multiple lesions are not uncommon, but more likely it is that one is a primary lesion and other probably the smaller one is probably a lymph node.
Sir,
What
the
else?
and the surrounding meso means their mesocolon also it is infiltrated probably. They have written.
What else?
And sir, this mass is means obliterating the means base of the appendix, means from which appendix is getting dilated.
So it is causing obstruction of the appendix.
Appendix.
Okay, fine. What are the important negative? If this is the complete ultrasound report, you should also say that it doesn't
Sir,
show.
any sir ascites
Yes.
or liver, any liver space occupying
So you should
lesion.
always, if a report is given to you, you should always mention the important negative findings also.
Okay.
Okay, yeah, carry on.
Sir, colonoscopy.
Fine.
Sir, there is a non-negotiable structurous growth is there at hepatic flexure.
So do you agree with this finding?
No, sir, because it was in the Caecum. So
what is
probably,
right? Which is right? Your examination is right or colonoscopy is correct?
sir, examination find. Sir, examination because we can see the lump is there in Caecum only.
So why are they saying hepatic flexure? So at colonoscopy, unless the patient is thin built and you can really see the trans illumination across the abdominal wall, sometimes location can be fallacious because they locate depending on the traversing the sigmoid, traversing the splenic flexure, traversing the hepatic flexure. So this is a frequent problem in colonoscopy, that the exact location of the lesion may not be correct.
Yes.
Only thing that if Caecum, they will be able to see that ideal opening.
Yes, sir.
Unless the lump has totally
Involved.
uprooted that.
Yes.
Yes, sir.
Okay.
Which is a possibility because patient is having featured the
Biopsy.
Based on the last three investigations which you have said, just like to add one thing is that you said about chest X-ray.
Yes, sir.
I think maybe this is not for the exams. For exam, it is still the chest X-ray, but for a practical this thing that after COVID, it has been found that HRCT is a better investigation to evaluate for chest because that will still show metastasis if they are present, which may not be seen on CT scan or on chest X-ray. One thing. Second thing is when you were talking about sonography, USG, everything was asked, and I think very simple thing which you should see always on a sonography, you should ask for a sonologist is when there is a right light to masses about the kidney and the hydronephrosis. Yeah. That is again a subtle marker which will make you prepared better. Definitely, you will get a CT scan done. And third thing, what Dr. Kapoor is saying about colonoscopy, you may not find exact location of the lesion on colonoscopy. It is usually very wrong when it is in transverse colon hepatic flexure lesion. It may be mislocated. So what is a better investigation to locate the lesion?
Sir, CT scan.
So CT scan. So that's what the next investigation should be.
Yes.
And in ultrasound, all those points you told before when you were discussing which investigation first, and you did mention about the lymph node, the additional points which you are giving in favor of why you will do an ultrasound first, that it excludes or includes the presence of mets in the liver, lymph nodes, the ascites, and the aorta involvement and hydronephrosis. That ultrasound will tell immediately.
Yes.
But when you read that finding, what we Dr. Ajay also telling, Dr. Kapoor also told you that you should have, if that report is there, it's okay. But you should have mentioned that, sir, these points have not been mentioned in this. So then the examiner knows, yes, you know what you want in ultrasound.
Okay.
Yeah.
So what Dr. Chaube is trying to emphasize is that if you are given an incomplete report of an investigation, after analyzing the report, you should say that this report is incomplete in this respect. I would have wanted this information also.
Okay.
Okay. Yeah. Next.
So biopsy reports are it is moderately differentiated adenocarcinoma and tumor marker CE is 1.3 nanogram per ml.
Why do a tumor marker when you have a positive report of malignancy?
Sir, for prognosis and for prognosticate the disease.
Does it predict prognosis? Does the level of tumor marker?
Sir, if the level is very high and after surgery it becomes down, so then it will show means good prognosis, means good prognostic marker.
If CA is normal, if the CA is normal, like in this case, what are the factors that would account for a normal CA? That is one question. And if the CA is very much raised, what would be the indication of that? What would it mean?
So if CA is very much high, there is chances of metastasis may be high. And if CA is normal, we can suspect means malignancy doesn't active cell or necrosis is there. Tumor cells are not secreting this CA.
So a better answer would be a normal CA does not rule out, it's not a diagnostic investigation, number one. So a normal CA does not rule out malignancy. Second, you were right that if the CA level is very high, what will be the cutoff, Subhash or Rajind, anybody, Ajay, where we suspect that there could be malignancy and that could become then an indication maybe for a PET scan? I'm not sure what is.
It's not indicated that way, but any CA above 400 ought to have a poor is a poor prognostic marker for CA colon.
Okay. Yeah, and so the most important role of CA is number one, to say whether the disease is advanced. Number two, as you rightly said, prognosis, and number three, for follow-up.
And the normal level of CA?
Yeah.
Sir, less than 4. Less than 4 to 7.
What is the abnormal level of CA?
So more than
4.5 should be abnormal.
Sir, 4 to 7 is normal.
4 to 7 is normal. You said less than 4 is normal. And I say more than 9 is significant.
Yes.
So what is the relevance of 4 to 9? I think any of our residents?
Smokers.
Yeah.
Yeah, so you should say in a non-smoker.
That is the most important for CA.
Normal level in a smoker is higher.
Yes, sir.
So you, whenever you describe CA level, you have to, normal CA level, you have to add that in a non-smoker, the normal CA level is whatever it is. Upper limit 4, 4.5. 4.
4 to 9 is seen in smokers, also
Okay.
more than 9 is
Yeah.
even difference according to the gender. Male, female, male. Both of
Achha. Okay.
So,
Yeah, Dr. Vinay says that even in male and female, there is a subtle difference, but check on that. You should know all these minor points. Yeah.
Okay.
And so in this case, CA is normal. So is it going to help you in follow-up? Will you do her CA levels during follow-up also?
Yes, sir.
Because anyway,
Sir,
it is normal.
No. Sir, if during recurrence it can means if it increases during follow-up, it can suggest means
But she's a
recurrence.
non-secretor. She's a non-secretor.
what will that suggest? Patient is having CA preoperatively 1.3 and 1 year after the surgery, she has a CA level of 84. What will that signify? That's what you're
One is,
Sir, either sir recurrence or new means metachronous growth.
is it possible that now the CA is normal and even before surgery it is normal and during follow-up it becomes high?
Yes, sir.
Yeah, so you're right. One is that it is another lesion which is now secreting, and second, even non-secretors, the metastasis can be secreting.
Yes.
So even if the pre-op CA is normal, it doesn't mean that it is not going to be useful in follow-up. You should get CA levels in follow-up in all patients, whether they are normal or high. Okay?
Okay, sir. Yes.
I think we are already at 10, but Ankur, if you agree, we can discuss the remaining part, the management and the surgery, right hemicolectomy and other procedures. And we haven't touched on tuberculosis, so maybe we can do that in a later session. So check with Dr. Anand. He has gone to the OT, but check with him in the evening. He will give you another slot to complete this discussion. There is a question or comment by Govind. Ajay, you can.
In a non-smoker, if the CA comes as 5 to 6, should be repeated after 3 weeks or should we further investigate in the first instance itself if we got.
So Govind, can you come in? Are you talking of this patient or are you talking in general of a patient who just...
in general, sir. I am talking in general. We often get such scenarios where people are referred to us by GPs just because their CAs came high and the CAs have been done for no reason. So,
then I would agree with you that I'll probably repeat it after some time and see whether it remains elevated or it comes to normal. I don't know whether I would, how strongly I will investigate a CA of 5 to 6, depending on the age, depending on the symptomatology of the patient. But if the patient is completely asymptomatic, I don't know whether a CA of 5 to 6 warrants a colonoscopic evaluation. I'm not sure.
CA done.
He says that sometimes as a health checkup. Some of the routine health checkups include tumor markers.
Because this routine checkup.
Yes, sir. These patients come to us with master health checkup. That's the problem.
I think it would depend on the age and probably if it is a routine checkup, I probably would not investigate, except that I may do a stool occult blood. This may be a situation where, as Rajendra was saying, if the stool occult blood is also negative on 3 consecutive days, I probably would just repeat it after 3 months or so.
Stool checkup, that is another very difficult investigation.
Yeah. So we are already at 10:05. Anybody has to say anything on the discussion so far? Otherwise, we'll continue this as a second session to complete the rest of the story. And in the meantime, students, you can send me a mail, vkkapoor.india@gmail.com, write RIF in the subject of the mail. So I'll send you the chapter on the analysis of the right iliac fossa lump. Yeah? Okay. So we'll close the session. Thank you, Ankur. Thank you. Thank you very much.
Thank you, sir. Thank you.
Okay. Thank you, Rajen, Subhash. Thank you.
Thank you, sir.
Thank you.